Hello. I'd like to welcome all of you back to start our third session of the meeting. And the third session will be the role of the genomic learning healthcare system in increasing health equity and access to genomic healthcare. I'd like to introduce our two moderators. First is Gail Jarvik, who's a joint professor of medicine and genome sciences at the University of Washington, and Kareem Watson, who is the Chief Engagement Officer at the National Institutes of Health's All of Us research program. So Gail and Kareem, I'll turn it over to you to introduce the panelists.
Thank you so much, Pat, and welcome to you all, and excited to be here. It's been a great discussion, the great kickoff for day one, and excited to continue the conversation. This next session, we're going to talk about the role of genomic learning healthcare systems in increasing health equity and access to genomic healthcare. And we're also going to be joined by four amazing panelists, and we're going to introduce them, and after that, my colleague, Dr. Jarvik, will lead us from there. So without further ado, we know that you have access to their bios. Just want to first introduce Dr. Jania Jeff, who's going to open us up, followed by Dr. Latrice Landry, Carol Horowitz, and Devin McGraw following that. Thank you all, and looking forward to this amazing conversation. We will monitor the chat and questions for brief clarifying questions after each of their 15-minute presentations, but really excited about the 60-minute discussion we'll have at the end following their discussions.
Janina, why don't you get us started?
Hi, everyone. Can you hear me okay?
We sure can.
Okay, perfect. So the title of my talk is Coded Bias, Identifying Biases in GLHS Data and Implementation. And so I do have a few disclosures. This presentation is just a small glimpse of the type of biases we would see in these systems. Also, that this work is reflection of my own work and not the work of my employer, which is Illumina. I do want to start off with talking about biases in other automated learning systems. And so a couple of years ago, a paper was published on a system called Compass. And so what Compass was used for, it was used by judges in Florida to help decide whether a person charged with a crime should be released from jail before trial. And so without knowing any information about individuals, previous information on whether or not these particular groups were more likely to be arrested were used as a basis for building this algorithm. And the purpose of the algorithm was to identify individuals who were considered high risk. And so if you were to take these two groups, one in the purple and the other in the blue, and both of which have individuals who are identified as high risk, you would already see that the purple group already has more individuals identified or unfairly targeted for arrest in the first place. And so this might give insight that there could be something else that is causing it, something unique to this particular group that is causing them to be high risk. If we were to run this Compass algorithm, in this data, they show that there are a significant amount of false positives, and these false positives are not uniformly distributed between the two groups. In the blue group, you only have 14%, or 1 out of 7 of individuals who were a false positive, whereas in the purple group, you have 50%, 2 out of the 4, who are given a false positive. And so really what this is kind of highlighting is that there could be a confounding variable in the purple group. And if we were thinking about the criminal justice system, we know a lot of this could be due to race being a confounding variable. And those who are of a particular, who experience racial injustice would likely be more likely to be arrested, and therefore have that historical information that's biasing this algorithm development. There are some examples that you see this in healthcare, and so one of which was published in 2019 using a risk prediction tool for 200 million people in the United States. And this algorithm took into account, it created a score, and this score was based off of the raw insurance claims over the course of a year, as well as demographic data such as age and sex, insurance type, diagnosis, procedure codes, medications, and detailed costs. All of this was used to create this algorithm risk score. And what the researchers found is that if they were to also take the total medical expenditure, and also I should say this risk score does not include race. If they were to take the total medical expenditure and then look at race, and here Black is purple and white is yellow, you would see that there was no significant differences. And in fact, those who have a risk score of 55% or higher were referred for additional screening, and those who were 97% or higher were defaulted into this program. And I forgot to say, this program is for high risk care management. And so you don't really see the biases there. But if you do know a lot about how the algorithm is developed, and you do know a lot about how, and you have a lot of prior information on how this works, you might be able to pull out a few key things. And one of the things that the authors pulled out was the amount of chronic illnesses. And so if you were to plot the amount of chronic illnesses against the mean total medical expenditure, which is the cost, you would notice that Black patients are actually more sick in some cases, but less is spent on their medical expenditure. This means that physicians are not ordering as many tests, not as many medications are being prescribed. Therefore, their total medical expenditure is a lot lower. And so you can see the problem of using an algorithmic risk score that is based off of medical costs could have a confounding effect, with race being that underlying factor that could be driving this. And as a result, Black patients that need the care are not defaulted into these high risk management programs. So we have some similar things in genetics as well, one of which is around the classification and annotation of genetic variants. And in 2016, there was a paper published on hypertrophic cardiomyopathy that showed that a lot of the pathogenic variants, and one of the characteristics of that is having low minor allele frequencies, having rare minor allele frequencies in a particular population is a signal for pathogenicity, and saw that the penetrance of those quote unquote pathogenic variants were not equal between different populations. In fact, African descendants in this context had much higher allele frequencies for the variants in these genes compared to the European descendants. And so as a result of that, these patients were misclassified as being high risk when in fact they weren't. And that can be for a lot of different reasons, one of which that we talk about a lot is really trying to understand which causal variants, what are the causal variants, and if those causal variants vary between different populations. Another thing is we can think about how can we use other information. And so ClinVar classifies variants and has a lot of annotations that do things like looking at how often the variant has been submitted into ClinVar, also looking at if the variant had been reviewed by a clinical genetics board and so forth. And so using these different criteria, now I'm referring to the figure on the right with different sets, you can see that inflation here, which is really just described by the expected population prevalence using ClinVar, and the observed genetic risk versus the expected population prevalence, is really high for variants that actually have conflicting interpretations compared to set one, which are variants that don't have conflicting interpretations that actually are quite robust and have been reviewed by medical boards and so forth. But even in that group, you see about 11.5% of the genetic disorders have inflation with pathogenic variant sets. And so all of these biases are, different types of biases that could be present in EHRs. In 2018, there was a paper that really talked really deeply about the biases, particularly in machine learning algorithms that are used in EHRs, and summarized some of the potential sources of bias, one of which being missing data. So patients who go to multiple healthcare facilities for care may have missing data in one versus the other. Also, for patients who have low health literacy, there could be missing data. And so really the question is, how are these algorithms treating these cases that have missing data? And a lot of the missing data, for example, health literacy, could also be associated with ethnicity in the case of non-English speakers. Sample size is another one. And so certain subgroups of patients may not exist in sufficient numbers for the predictive algorithm. And that could lead to overfitting. It could also lead to underestimation and misclassification of models. And then misclassification or measurement effect. And so patients of low socioeconomic status may be more likely seen in teaching clinics, and these teaching clinics could have more errors in data input. And so in this case, this would mean the algorithm would be inaccurately learning data that is false to begin with. But there are other forms of biases that are not talked about in this table. And so one of which is the incorrect use of data itself. And so this is the incorrect use of data to predict outcomes. And we have a lot of examples of that in the healthcare network, particularly around demographic data. And I'll show some examples in regards to race. But others are underestimation, which is the state in which a classifier had not yet converged. And a lot of times this is the case with genomics, when we don't understand or know what the causal variant is, therefore our genetic variant may not be incorporated in the model at all. And then there are some other ones like prejudice, and this is coming from the fairness statistical paper I'll talk about in a little bit, which is the statistical dependence between sensitive features. And so this is meaning that your model is dependent on a demographic or feature that could cause more disparity. Or negative legacy, which is unfair sampling and label, which is similar to what we talked about in the table. So to give some examples of the incorrect use of data that themselves are biased, I want to talk about some misuse of race in existing prediction scores. And so these are just two examples. One, using a VBAC risk calculator. And so this is to calculate risk for women who have had C-section, their likelihood or success rate of them having a vaginal birth after having a C-section. And so the input variables to determine this risk calculator include age, BMI, prior vaginal delivery, prior VBAC, indication of a C-section, but also African-American race or Hispanic ethnicity. And so when looking closer at this model, race is subtracted from the success rate of any person identified. And that percentage is actually just as large as something that we know that is directly correlated with the risk of having a VBAC, which is previous vaginal delivery. And so if we were to use this, and race here being inaccurately used, Black and Hispanic patients are less likely to get counsel on labor options and are encouraged to deliver by C-section without any medical evidence supporting race as a claim. Now, another example that we talk a lot about in genetics is EGFR and kidney disease. And so there are equations that are based now, that were based, and some still are based off of, largely based off of CM creatinine, age, sex, and race. And these equations are supposed to account for the fact that African descendant populations have a higher prevalence of kidney disease compared to other populations. And so using these equations, thinking about patients who have the same creatinine measurements, these equations will yield to higher EGFR in Black patients. And so what this does is it suggests that there is better kidney function, and that can delay referrals to nephrology or specialty care for these patients. Now, I should say that this is something that is evolving and changing in our field, as we know that these equations are now being modified to include APOL1 genotype instead of race, as APOL1 genotype is a much more accurate predictor of kidney disease than race itself. There are some things that we can do to address this model discrimination, and one of them is the C statistic. And so the C statistic is a measure of concordance between the model-based risk estimate and the observed events. And so one thing to note is that it is independent of prevalence outcome, but majority of EHR risk prediction studies do report these C statistics in their analyses as a metric of discrimination in their models. And so again, this is not an end-all be-all, but when reporting this C statistic, you can see that there's a high level of concordance in this instance across 90 different EHR algorithm risk prediction studies. for clinical and mortality. They're pretty high, they're over 0.8. Now, few studies actually report the potential impact on clinical decision-making. So again, this C statistic is not based off of prevalence outcomes. So in order to do that, we would need to do something like a positive PPV, a positive predictive variable, which also takes into account the prevalence. So one of the things that is really important to note is that these do not access the model to assign accurate probabilities of an event. This would require calibration. And so calibration is performed and reported by some studies, but not many. So what does this remedy look like? What are different ways in which these remedies can look? And so I kind of call this debiasing algorithms, and there are a lot of different methods in order for which you can do that. I won't have time to talk about all of the details here, but what I do want to point out is the difference between using two different approaches. And so one approach is a reweighted approach versus a prejudice removed approach. And so in this example, the researchers are looking at postpartum depression as defined by ICD-10 codes and prescription of depression medication, or the utilization of mental health service utilization. So this basically just means that you are going to a mental health service clinic. And so in the darkest bar is the base model, which, as you can see, is not doing a great job of estimating disparate impact. And so disparate impact is a measure of equality. And so it's equal opportunity difference, but disparate impact is not taking into account the accuracy of the actual preferred outcome in this case. And so in this case, the preferred outcome is being able to accurately predict postpartum depression or mental health service utilization. However, when doing this reweighting, and so the reweighting in this instance is based off of the fact that some groups may be experiencing privilege versus unprivileged. And so if we were to take that and consider that as a weight in our model, we can more accurately predict these outcomes. And so when doing that, we see that we are able to better predict this postpartum depression and the mental health utilization. And so the equal opportunity difference is a more accurate way of doing that. And so if we're looking at both the reweighted and the prejudice model, we see that the reweighted model does a much better job of that when we're taking into account the accuracy of the actual outcome. So there are other approaches, going back to the example with the healthcare network and using healthcare costs as a metric. This approach is called relabeling. And so if you know a lot about the model, then you are able to understand or pull out signatures that could be confounding the algorithm development. In this case, the use of the amount of medical expenditures being used. And if you were to relabel that and then look at the original versus simulated data, we can see that the fraction of Black participants in that original study are now being defaulted into the program once we take into account and redo our algorithm based off of chronic illness in addition to medical expenditure. And so there are a lot of things that we can do to debias algorithm development. And I just quickly listed out 9 here. I won't go through all of them, but I'll talk about some of the big key ones. So one of the ones that I like to talk about a lot is the intent behind design. So choosing the appropriate questions and settings for these algorithms. And this is really important. I would say it's all encompassing because not only does it talk about how we create a study, but also being able to ask the appropriate questions, meaning that we also want to have diverse scientists included in that process. And so these other things that are really important to monitor is that whenever we're talking about biases, we have to look at it at every section of a study. This is before we collect data, while we're collecting data, while we're developing the algorithm, and even post data collection and algorithm results. We want to make sure that every step of this is not being subject to any type of bias. And so I would say one of the bigger things that we are trying to understand in genomics is what is the knowledge underlying causal structures. We actually don't know a lot of the genomics that is causing a lot of the phenotypes that we are using. And so there are a lot of different ways in which we can perpetuate bias, and I only have 15 minutes to talk about a few of them, but hopefully this was helpful. So one of the favorite quotes that I like from Ruha Benjamin, which is, "Today, coded inequity is perpetuated precisely because those who design and adopt such tools are not thinking carefully about systemic racism." Going back into the study that was looking at medical cost expenditures, we really have to understand how systemic racism is ingrained in a lot of healthcare, in a lot of the healthcare and the data that we collect and the questions that we ask and the methods that we use in order to really understand and eliminate some of these biases. And I just want to say today, I'm only talking about racial biases, but of course, there are several different biases that could exist within an EHR.
Thank you, Dr. Jeff. We're right at time, and we do want to say if there's one clarifying question that someone may have about the presentation, but do want to remind our attendees that we will have a full discussion at the end of all of our presenters. But thank you for that amazing opening, Dr. Jeff. And there is a question in the Q&A related to around the social construct of race that I think we can save for the larger discussion question. So with the interest of time, we will now have Dr. Latrice Landry.
Thank you for that. Can you guys hear me now?
We can hear you now, yes.
Wonderful. Well, thank you for that, Janina. It's always a pleasure to be on a panel with someone who is both like-minded and very insightful in this space. Today, I'll be talking to you all about utilizing genomic learning health systems data to increase equity and access. I'm going to frame today's conversation around three key components. And these components are thinking about the imperative, the implicates, and the impact of our pursuit of equity in genomic medicine. So let's first start talking about the imperative. So often when I think about our imperative in pursuing equity in genomic medicine, I like to frame it around genetic testing, as genetic testing is key to precision medicine. And specifically, I think genetic testing as a platform for discussing this allows us to think about genetic testing and genomic medicine in the component of biomarkers. And we can think about biomarkers and specific biomarker types, DNA being one of the types of biomarkers. But we can also think about the application of biomarkers. Now, I like to think about this in the application of biomarkers using the FDA and NIH Leadership Council on Biomarkers framework, which includes several classifications of biomarkers, including diagnostic biomarkers, predictive biomarkers, which are predictive of treatment, prognostic biomarkers, and risk-based biomarkers. So when we think about that, we can think about biomarkers not as a single type of biomarker and not in a single application. And I think when we think about the body of genetic research and thinking and breaking it down into biomarkers and all the different applications of biomarkers, it allows us to ask some very different questions about our body of research. Now that we're thinking about biomarkers as the key to precision medicine and genomic medicine, I think it's important to think about this in the context of the translational research framework. The translational research framework, which was put forth by the field of translational epidemiology and has been around for quite some time, is broken down to a few key stages. Stage 1 is T0, which captures basic research. T1 is stage 2, which captures translation research to humans. T2 is translation to patients. T3, biomarker research, is translation to practice. And T4 is translation to communities. When we think about this, quite often people like to break it down to two key classification areas, which would be type 1 translational research, or the early stages of biomarker research, and type 2, which is the latter stages of translational research. However, when we think about this in key fields that drive biomarker research, we can break it down into four key fields. The first being the idea of discovery, research on discovery of biomarkers, thinking about clinical trials, health services research and implementation science, and then public health research. Now, I think that framework allows us to think about genomic research and biomarker translation as a key component to genomic research, and in terms of the impact of that on the field of genomic medicine. But I'd also like to think about this, and this is a data that you guys have seen probably in many different formats, but here I present the view of databases or population diversity in databases in two key pie charts. The pie chart on the left represents our global population. And although it fluctuates moment by moment, day to day, it's relatively stable over time. And we can say roughly our global population is about 15% European, resulting in 85% of the global population, which is non-European. However, when we look at our genomic research landscape, we find that around 71% of all genomic cohorts from two key databases are focused on 100% European populations as defined by those cohorts, leaving about 29% of the cohorts to be non-European. Now, this pie chart fluctuates by disease type and body of research, with some disease areas being comprised of 100% European cohorts, representing roughly 0 of the global population that is non-European. It's important to think about this in the context of biomarkers and biomarker translation around the translational framework, because I think that's key to ask to the questions that we ask, as Dr. Jeff just presented. Now, when we think about the questions that we can ask and the resulting impact of this lack of diversity on genomic research in diverse populations, and the impact specifically on genomic testing and genetic testing as biomarkers are key to precision medicine, we start to ask questions about, well, which biomarkers are absent. We start to ask questions about both the efficacy and safety of specific biomarkers for diverse populations, otherwise captured in a variable called generalizability of those biomarkers. We can also ask questions about accuracy. And again, accuracy can be broken down by the different classifications of biomarkers. Again, those include risk biomarkers, biomarkers that are designed to capture diagnosis, as well as prognosis, as well as pharmacogenomic biomarkers, and then biomarkers that are specific to treatment or otherwise characterized by the FDA and NIH Leadership Council as predictive biomarkers. We can also ask questions about both access and policy. Again, the translational research framework goes from basic science research all the way to public health. And so the question of what's missing isn't specifically focused on one area. It's a question we need to ask about all areas of the translational paradigm. Now, when we think about the current state of research on equity, diversity, and disparities in genomic research, we're capturing a key demographic of the research. That is both the absence of biomarkers and questions about efficacy and safety. However, what's largely missing in a lot of the dialogue and discourse are the questions about the T3 and T4 stages of the translational framework. Primarily, if we think about it in this way, the lack of focus on equity-based research in T3, T4 will result in furthering harm. It will further disparities. Can you imagine a world in which we have a more diverse set of biomarkers, more options on genetic testing, but not everyone still gets the test? And I think that one of the things we have to be very mindful as we invest large amounts of research into achieving precision medicine, optimizing genomic medicine towards that goal, is how well are we doing in building the system to target all of these areas? Now, one of the things I'd like to put forth in terms of how we got here and why we may not be capturing T3, T4 is going back to those pie charts I showed. Now, I mentioned that a lot of us may have seen that data, but that data is really about discovery. There have been lots of studies that have put forth between genomic databases, primarily the Genome-Wide Association Study Catalog database, the database for phenotypes and genotypes, and other genomic databases which capture genomic research, which shows us that the genomic research is largely missing research on discovery in diverse populations. However, I think that what I'm putting forth here is the genomic learning health system, which captures data in the translation to practice, T3, and translation to communities areas. If you think about it, an electronic health record really captures information on what's being practiced. And so here we can think about the genomic learning health system as a key tool to helping us achieve research on equity, diversity, and disparities in T3, T4 research. Now I'd like to move on to discussing the implicates in our pursuit of equity of genomic medicine. Again, the idea here is building an equity-focused genomic learning health system. Now, many of you have seen this framework that's been put forth that sort of brilliantly captures the complexity of a learning health system, right? It captures both the data, the knowledge, and the practice, and the synergy between those entities as we capture other components, mainly the complexity. We think about the strategy and the rationale that we're trying to achieve in our learning health system on a local, regional, national, and international level. I think one of the things as we put forth frameworks, and I love this framework, but one of the things I see is missing is as we capture it and we think about both the established monitoring system that it's suggesting, the systematic evaluation that is required, the engagement of diverse stakeholders that's embodied in the complexity, as well as the coordinated implementation to achieve a learning health system that is readily implemented on an international level. The key thing that's missing here is the focus on equity. Again, I put forth a premise that if we do not build it into the system, we will not capture it by accident. I think when Dr. Jeff was speaking before and talking about thinking about systemic racism and thinking about the key stakeholders and how things get built, I think one of the things here is that diversity, equity, disparities research has always been a niche field studied by a few. And so in that sense, when we engineer the system, we don't necessarily think about, are we monitoring and evaluating equity at the forefront of the system, right? So equity is an afterthought, is inequity at the forethought, right? And that's something that I've said before, but I also think it's really important as we build learning health systems that we think, are we establishing equity in our learning and our monitoring and evaluation system? Meaning, do we have metrics and key variables that we're evaluating over time? Is there a systematic evaluation of equity at certain time points? Are we monitoring how we're doing? Do we give ourselves a report on equity? Do we think about engagement, not just of stakeholders, meaning those with power, but also thinking about diverse stakeholders and thinking about achieving equity within those who are not currently in the system? As well as coordinated implementation, not just in the major academic centers and the powerhouses that drive our research and our research landscapes, but also coordinated implementation around diverse healthcare settings and diverse populations. Are we meeting the challenges of building the infrastructure that is required for a learning health system that will achieve equity? I think these questions become apparent when we think about the example of the COVID-19 pandemic. Early in the pandemic, there were many that were concerned based on their on-the-ground experience that the pandemic may be impacting certain communities more than others. Here, later we were able to see in a series of publications and published results from the Centers for Disease Control that there were, in fact, disparate outcomes by COVID-19. These disparate outcomes were exemplified in the hospitalization rates around racial and ethnic minorities, as well as the mortality rates and the case rates by themselves. Now, one of the key things that happened early in the pandemic when there was a call for release the data stratified by racial and ethnic groups is there was a clear issue that was being put forth by those who held the data, simply that they could not break it down by race and ethnic groups because it had not been structured in that way. The system had not been designed to answer that question, and therefore it could not be answered. Secondly, there were a few key policymakers that were suggesting that even in cases where the data was available, it was not being shared because of fear of institutional harm, meaning that there was no obligation to share the data. And so it took high levels of people high up to really compel the release of the data so that we could actually monitor how we were doing. The system wasn't built to make sure that we were achieving equity around racial and ethnic groups. And again, that is not the only space that we need equity. However, it was one of the ways in which it was defined and one of the key outcomes that was helpful in sort of targeting resources at the end or towards the end of the first year or first stage of the pandemic. Now, many of you have seen slides similar to this one, which captures this idea of inequality, equality, equity, and justice as different entities. Inequality being an unequal access to opportunities, equality being evenly distributed tools and assistance to achieve access, equity being the custom tools that identify and address inequalities, and justice being fixing the system to offer equal access to both tools and opportunities. I think that the just model is the one that we want to achieve, and it's one of the things that we can really think about at this moment where a ton of investment is going into building genomic medicine. Part of the issue that we've always had with equity and disparities is that the system wasn't built to capture it. But if we build the system to capture it, then we have a way in which we can monitor and evaluate progress over time. Instead of having big engineering endeavors that we need to do to fix a problem, we can fix the problem as we see it in real time. Again, therefore, the obligates of equity-based implementation science, including established monitoring system, systematic evaluation, engagement of stakeholders, and consensus building across diverse groups, all require 4 I's: inclusion, investment, infrastructure, and implementation. And I remind you that the infrastructure and the implementation and investment in the inclusion includes populations that are currently currently do not have a seat at the table. Now I'll leave you with this, and this is just thinking about the impact of our pursuit of equity on genomic medicine. I think we can all envision a world where we pursue equity in genomic medicine. Is currently my passion, has been sort of the focus of all of my research and work from both graduate school to today. But I'm a molecular epidemiologist at heart. I was where my PhD was focused on epidemiology. And so I like to think about it in the context of this. So we're pursuing equity in genomic medicine. Genomic medicine is a key to precision medicine. And when you're an epidemiologist and you first start to think about precision, you're always presented with this bullseye chart, right? And so the idea of the bullseye is that if you have something that looks like this, your data is both accurate and precise. It is accurate because it hits the bullseye. It is precise because each of the points overlaps one another. If we can imagine that our current research landscape and both T0 research, T1 research, T2, T3, and T4, all the way to public health impact, is currently focused on a single population, and we look at this and we feel like we're getting to precision medicine. However, as we include diverse populations, if this is what we see, our landscape is neither accurate or precise. And so I think one of the things I want to leave you with is that precision medicine requires an equitable, just system, and that requires us to work to build it. Now, if you want to achieve equity, you need to build it into the genomic learning health system. This is how we utilize a genomic learning health system to achieve both equity and access. And again, I'd like to thank our moderators as well as our conference organizers for including me, and I'll leave you with that.
Thank you so much for that important talk, Dr. Landry. Our next speaker is Dr. Carol Horowitz. Carol.
Hi, everybody. It's really an honor to be with you all and to follow such excellent speakers. Can you see me and hear me?
Yes.
We can hear you and see you, yes.
Great. So I'm going to be talking about patient provider engagement in these genomic learning health systems. And I have no conflicts of interest. So I think we already know the why, and as Terry said, we need to get beyond the whys and figure out what we're going to do. Genomic medicine, the promise is not yet fully realized. To be more impactful, we need to get more clinical applications. To be more inclusive, as you heard, we need equitable and just impact and benefit. And if we focus outside of our area and look more intersectionally, then we can float all the boats and we can look at genes by, when I started this work, I heard about G by E would be something like a gene with blood pressure, but I think now we're realizing gene by environmental also includes all these other factors that we need to focus on. And what I want to focus a lot on is how we turn from a lot of the work we do now, where we view patients and frontline clinicians as receptors, and really move on to how they're going to be our partners. So here's the what.
Excuse me, Dr. Horowitz, I just wanted to see, were you sharing slides?
Oh, they're not showing?
They're not showing on the screen.
Well, that's a problem. Okay, thank you for saying that. Let's try again. Okay. Are we better now?
Yes.
How's that? Okay, all righty. Thank you. Okay, so moving on, perfect timing. So what we have is that, these systems are designed to get the results they get. So these are our systems, these are our choices, and we need to figure out what else we're going to do about them. So the first thing I wanted to talk about is, we're trying to tailor our EHR systems for genomic care and for genomic research. So I put in here quotes that I've taken notes on over the years. And this is one where we think about, who do we resource to help us? And one of the things I've heard people say is, well, I can't really have any docs or patients join me, because then it just is one patient or it's just one doc. And what does that represent? And that argument has tended to land a little bit hollow on me. I think they represent who they are and they bring a lot to the table. And as our community partners would say, if you're not at the table, you're on the menu. Also, instead of that, what we can think about is team science. And the way I like to think about team science is the difference between a pickup game and a team. And this means that when we're looking around at who we're working on to build these learning healthcare systems, we have to say, we need these people at the table. And if they're not there, if your pitcher or your first base person is not there, the game's not going to win. We're not going to win the game. So what that means is that we shouldn't be saying how do we help them? They should be at our table saying, what do we as clinicians want and need? What do we as patients want and need? And for us designing these help systems, we need to think about co-designing with them. So instead of learning from people, we're learning with them. Instead of deciding for them, we're deciding with them. Next, people are increasingly being asked to invite patients, advocate clinicians to join us in our activities. And what I sometimes have heard is kind of a resistance, like, I can't tailor my work for their understanding. This is hardcore science. They're never going to understand what I'm doing. But on the other hand, what I've heard is that if you really pursue the quality and not this as an obligation, what you're going to end up doing when you have people join is, when you change the way you do things, the things you do start to change. And I've seen time and time again, people who are a little hesitant invite somebody to a meeting to say, I don't think you're really going to help me, but I know I'm supposed to have diversity at my meeting of some type, so here you go. And then I see that same person starting to take notes and say, oh, wait, can you say a little more about that? Can we meet again about that? We don't know what we don't know. And by inviting people to our table, and as we call it, a good invitation to a great party, so you're making people feel welcome and they're having good experiences with you, you can really do more. We're under a lot of pressure, rightly so, from funders, from health systems leaders, to have higher enrollment into our studies, to have higher uptake into the clinical programs we're doing, to have greater benefit. But we sometimes fall short. We know that in clinical trials and clinical work, we don't always recruit as many people as we thought we would, and often as we promised we would. But this ends up introducing a very unfortunate implicit bias, that what we end up doing is we say, well, these patients are low literate, they're fatalistic, they're mistrustful. We kind of start turning the problems into blame and stigma. We look at frontline clinicians and say, oh, they don't care about genomics, they don't realize how much it's going to help their patients. And so what we do is we kind of blame rather than asking for help. And what I've seen more recently that I find really exciting is people instead employing curiosity and respect and saying, this is not working for me. What do I do? And as one person said, when we first invited frontline clinicians and community people and patients to work with us, first we felt really intimidated. We didn't want to show them our dirty laundry. We weren't sure how they were going to react. And we'd never worked with folks like that before. But we got engaged and we got more than we ever imagined. Another thing, look where beware what you say for last and follow the resources. I've heard time and time again, people say, I wish we had money for engagement, but we're over budget. Well, beware of how you're valuing things. And instead, we can say engagement costs are necessary and reasonable, and we can prioritize inclusion from the very beginning. If we put it in the beginning, we're going to keep doing it, and we're going to have the resources. Another example is in terms of how we engage stakeholders. I've heard folks say, well, we had a focus group, so our engagement is done. And a lot of our engagement historically has been passive, where people are advisors. And slowly we're moving toward having people be active partners instead. So I want to, say to you all, I don't know if you've heard this topic, equity tourism, this idea that, right now there's a real focus on equity in the last couple of years, and people might dip their toe in, but then they might take their body away. So going longitudinal will help in the long run. If you put together a group of people to help you, that same group can help you my group is helping me and we've been a team for a decade. So this is the gift that's going to keep on giving. So if we don't do equity tourism, when we build these systems and we build equity and engagement in our learning health systems, it's much easier to keep these going than to have fits and starts. And I want to remind folks not to pigeonhole. So a lot of times when we think about equity, you might say to somebody, can you review this patient education sheet? Can you review my consent form? And those things are really important. But as important are there's other ways we can bring people in. So PCORnet is an example of using big data and engagement. Recover is another example of using EHRs and using engagement and equity to change our outcomes. And I'm going to talk in a minute about how we're using this in our artificial intelligence and machine learning work. So to collaborate, the how is first, summing up that we need to understand each other. So we in this room are mostly clinicians and researchers that focus on genomic medicine. And if we compare ourselves to participants, local community, and a lot of other frontline clinicians, we see the value of our work. We understand it, but we have to understand why other folks have what I would call earned skepticism. Is this really, really going to help me? Is this really, really going to help my patients? And go to them with an understanding that that skepticism is reasonable to have, and it's up to us to help educate. We feel now for all this timeline, but a lot of our colleagues will say, what's the hurry? This has been going on for a long time. I'm seeing 12 patients today. I'm seeing 15 patients this morning. Do I need to stop and do this right now? We see the benefits as obvious, but a lot of other folks would say, the risks may outweigh the benefits if the risks are, if the benefits are not super clear. And that in what's going on in our health systems right now, there's so many problems. Is this really a top 10? And finally, and I find this really interesting, some of you met Elder Mimsy Robinson when he spoke to the CSER Consortium years ago. We often view patients as mistrusting. They need to trust us. But what Mimsy said to me that I really thought was fascinating is, you say we don't trust you. I think is the opposite. So I'm challenging you all to think about the fact that who's mistrusting who? If we really have trust in patients, in clinicians, in community stakeholders, we would be inviting them to the table. And so we need to be trustworthy and trusting. So now I'm going to go into some of the what's. And what I'm going to do is I'm going to give you an example of what's from a couple of different angles. And the first one, I didn't call out a lot of people, and I apologize if Ingrid and Robert, you're here and I didn't ask your permission, but I'm bragging, so I hope it's okay. So from a research perspective, in terms of how to build a small learning health system, the first lesson is to start on the ground floor and be open and generous. So what Ingrid and Robert and their Harvard team did is they started a BabySeq grant where they're doing whole genome sequencing of healthy babies. And they have not done engagement before, and they've done some work with diversity, but not tons and tons and tons. And they immediately set out and said, we are going to have a diverse stakeholder board starting our first month. Actually, we met before we even got the funding originally even started. And they, with generosity and with openness, transformed their entire study design and approach. So I urge you to reach out to them to hear about their journey. Another example is someone who's kind of on the translational angle. And here I'm going to talk about Erwin Boninger and the Mount Sinai Genomics team. A lot of you know about APOL1, you heard about it before. What you might not know is that Erwin Boninger first, when he was thinking about APOL1 research and whether or not we should be returning results to people outside of the transplant world, he came to a group of community people and said, and who were primarily had African ancestry, and said, what should I do with these results? Should we do something? And it wasn't until our community partners and clinicians agreed it was worthwhile that he went forward and started doing research, and I started joining him. And listening with that group leading us, we recruited 2,000 African ancestry adults on time. Most were retained in research. The study worked. Most of our sites, including federally qualified health centers and frontline clinics, had never had any research done in their sites. Most of the patients had never been part of research, and they loved it. Originally, everybody thought that all results, no matter what, had to be returned through genetic counselors. Instead, our patients and our qualitative research in the beginning found that genetic counselors were better off being senior leaders and teaching lay people how to return the results. It worked great. 98% of people were satisfied. We asked everyone if they wanted to meet with a genetic counselor for free. None took us up on it because they were satisfied. And these people became co-experts, authorities, and presenters. For example, they're the ones who said to Erwin and I, wait, if this APOL1 leads to problems with kidneys and Black people have more APOL1, Black people also live in neighborhoods with more air pollution. Is that bad for your kidneys? And it is. And sure enough, Girish Nadkarni and his team found an association and have an R01 looking at associations between APOL1 and air pollution. Another perspective is funders. And I want to point out how Lucia and Ebony and others at NHGRI have really systems levels at their disposal. So they formed an engagement work group. And they said, we are going to have engagement and every site is going to do engagement. And they have diversity targets. And everybody needed to show, are you recruiting diverse populations? Are you working with diverse populations and how? And when the funder says jump, we all say how high. And this is a great jump to take. And I want to talk about the C-suite. And here I'm going to give an example of something that we've done at Mount Sinai, or our C-suite at Mount Sinai has done, where they have a quality leadership council where a lot of the C-suite and health systems leaders come together and meet about quality. And they decided to lean in on looking at structural racism and work with our anti-racism roadmap, even though it was outside of their comfort zone and something most of them haven't done before, and to make their team a learning system to learn about how to do racially just work at Mount Sinai and give racially just care at Mount Sinai. So an example of that is that you all might have read recently, there's been some newer studies, but there's a bunch of studies over the last 10 years about how the way we write in electronic health records is biased, who we use the word hostile to describe, who we use the word non-compliant to describe, and how often we use it. And it's much more likely to be used in Black populations than in white populations, for example. So this group has said, you know what? We are going to not only look at the way we have bias in our EHR documentations as an example of racism in our health system that we need to eliminate, but we are going to invite diverse patients in to look at our problem and say, we need your help in making this a less biased system. So it's actually going to be the patients that are going to be training the clinicians about how to not be biased. And it's the patients who are going to be coming up with the AI and ML algorithms we use to see where the bias lies. So in summary, we do need culture and systems change. This is a type of culture and systems change. We will progress when we value, resource, rely on, or vulnerable with diverse patients, advocates, and clinicians. And we encourage you not only to transform your health systems into learning health systems, but also your teams, because if you do that, that's how you're going to operate. Start early, stick with it, and bring in lots of diverse talent. And I want to thank all of you and our fundings, and this is on behalf of our wonderful genomics board. Thank you all.
Thank you so much, Dr. Horowitz. Any clarifying questions before we bring in our last panelists? And I also want to encourage you all to put your questions in the Q&A so we can have them during our discussion as well. Thank you for that, Dr. Horowitz. Not seeing any questions, we'll move on to Devin McGraw, to end us up with our panel discussion before we open up for discussion.
Okay, let me get my slides up. Oops. Okay, can everyone see them?
We can.
Oh, terrific. Thank you, Kareem. I appreciate it. Okay, nice, very nice to be here. Nice to at least virtually see so many friends and colleagues, and grateful for the opportunity to present to you today on what we consider to be a patient-centered genomic learning health system. And I'll let you all decide if we're hitting the mark. I am Devin McGraw. I'm the lead for data stewardship and data sharing. So my primary conflict, if you want to consider it one, is that I am a salaried employee full-time of Invitae, also hold some minority shares in the company. So our mission is to bring comprehensive clinical genomic information into mainstream medical practice, as well as research, in order to improve healthcare for billions of people. Suspect that many of you, if not all of you, are familiar with us as a genetic testing company. I'm actually so this slide is about data silos, and we've spent most of the day talking about where they exist. And so it's not really telling folks anything new, but it certainly is in the deck if you want a copy of it. It's very difficult to pull all this information together from various sources, including information from the patient, in order to power patient care and power research. You know, again, I think most of you, if not all of you, are familiar with Invitae as a clinical genetic testing company. You know, we are, sort of part of this world because we process genetic samples and return test results. And we also contribute significantly to powering research, including sending variant data to ClinVar. But to really sort of power a learning health system, it needs both genomic data and phenotypic data as well. Data from medical records, data from the patients themselves, imaging, prescriptions, family history, lifestyle. So obviously having the genomic data is very important, but having the full complement of data about an individual is really what is rocket fuel, essentially, for a learning healthcare system. And about a year ago, Invitae acquired a company called Ciitizen, which I helped to co-found, which enables patients to gather all of their medical records from all of the places where they've been seen. We leverage the right the patients have under the HIPAA privacy rule to be able to get all the information that's been generated about them, and not just information that's available through the portal. And then it's really under their control to be able to use it and share it as they see fit. There were obvious synergies to the pairing with Invitae because while we had genetic test results for a number of Ciitizen users, we didn't necessarily have that data for all of them. And it certainly, with the two components together, Invitae and a patient-centered platform of data, it gives many more opportunities to be able to power both better medical care, better decision-making at the bedside, better decision-making by patients and their families, as well as enabling patients to power research forward. We've had some discussion today about the need to involve patients, the need to make sure that data is returned to patients, the need to assure that that data is returned to communities. And all of that is very important. What Ciitizen brings to the table is a little bit of the flipping of the model. So rather than just making sure that patients also get access to this data, we're essentially allowing patients to drive this research, to allow them to work, oftentimes working within patient advocacy organizations, to be able to even conduct some of this research on their own, much less partnering with various research organizations, companies in the medical product space, in order to find better treatments and cures. This really puts that data in their hands. And again, because we are accessing data from all of the places where the patient has been seen, plus the ability to generate surveys and additional real-world data from the patients themselves and include that within the record, the ability to get imaging and scan data, and have all of that with patient consent to be able to be leveraged for research purposes creates a model that is, while not necessarily unique to us, I see some others at the session here that are building similar models, is not typical for a genomic learning health system. So just a little more on this, on description on the slide about what we do. Again, it's really the patients who drive the creation of their accounts at Citizen. Medical records and images that are produced through leveraging the patient right of access, mostly by going to hospital information management departments, because to date, the data that has been available to patients through portals is a little skinny. It's getting better. It's definitely getting better, but oftentimes it doesn't include the genetic test data, with some exceptions that have been mentioned on this call, which is terrific. Images are often left out, but we are able to get it all. We've built an entire infrastructure to enable that data to be consumed. And then we are, through a combination of software and humans for quality review and accuracy, extracting the relevant data elements out of these records in order to create an actionable summary that the patient can use in patient care, that can be matched to clinical trials in some circumstances, and also to be able to be shared with researchers, again, with the patient's consent to do that. This is just a sort of a bit of a better view of the extraction methodology. Again, largely training software to be able to do this more quickly than human abstractors, but with human review for quality, and always provenance to the original documentation where this information came from. So again, we work with patient advocacy groups, both to recruit patients onto the platform, but also to help facilitate patient-led research. We started in some cancer subtypes, breast, cholangiocarcinoma, and blood cancers, largely because of some early partnerships that we were able to forge with patient advocacy groups. We also have a partnership with Touch, which is the Black Breast Cancer Initiative, that is aimed at, they have an initiative called When We Trial that we are helping them with in order to educate Black women around the opportunities around clinical trials. Another thing that we are able to do, if the patient is interested in it, is to actually provide them with a report that shows the clinical trials for which they meet the inclusion criteria and that are in geography that works for them in terms of potentially being able to enroll. We don't enroll them, but the machinery is there to sort of facilitate that. But the aim is not to jump over the patient's oncologist, but to provide additional information to the patient that can be discussed with the oncologist. And we have facilitated the enrollment of patients in clinical trials through this technology. Some of the other advocacy groups that we've worked with is the Leukemia and Lymphoma Society. We were able to help them power a research study on the efficacy of COVID-19 vaccines in this population. There's not a genomic component to the study, but it just gives you a sense of how this can work. Essentially, in less than 6 months from having the idea to publication, helped tremendously by the rapid publication schedules around COVID-19 related research, but nevertheless, 6 months from idea to publication of what was the Leukemia and Lymphoma Society's first author publication. So a study that they did using the data that we helped collect to populate their registry, shared into their registry with patient consent. There was also a biosample collection component to this. But the data piece of it, the medical records piece of that all came from data that came from the participants' citizen profiles consented to be shared with LLS Registry for research purposes. The other area that we are actively involved in and that we are investing heavily in is rare neurological disorders, characterized by, most of them characterized by genetic issues as well as seizures, seizure disorders. And in that circumstance, there are a number of instances where the data that we are supplying to the researcher is aimed at submission to the FDA in medical product review. Again, in rare neuro, often in partnership with the patient advocacy organization, and all consented by the patients. So just to sum up, leveraging the routes that are available to access patient data, we are not currently directly connecting into patient portals for a couple of reasons. One, historically, the data has been a bit skimpy. Again, that is definitely improving, but we also have noticed that sometimes it creates some obstacles to data collection when people don't remember their passwords, or their password connection through the portal times out, and they have to remember it and reconnect the patient-facing record into the EHR. I think a lot of those issues will get resolved as the technology matures, but we didn't have the time for that. And so we've been pursuing lots of other avenues, including looking at health information exchanges and health information networks, which exist across the country, and are subject to the federal information blocking rules, with the expectation that they make data available to patients at their request, in order to see if we can get a good complement of data much more quickly than is the case for us today. And again, increasingly combining genetic testing and relevant clinical data with responsible sharing of the data at the direction of the patient, when the patient tells us that they want to share it with their clinician, for example, or with patient consent for more of these group data sharing opportunities. Even when the data are de-identified, we request their consent for sharing. And then, of course, Invitae continues, even with its patient population of genetic data, where we don't have individuals who have opened up citizen accounts, to continue to share data to advance genomic medicine, including with ClinVar, and also sharing data with the patients through portals, and giving them opportunities to choose whether or not they want their research to be shared. I think my last slide is just for those of you who are not familiar with what a health information exchange or a health information network is. I thought it might be worth a little snapshot that comes from one of the associations for health information networks across the country, which used to be called SHIEC, Chic, and is now called Civitas Health Networks. Again, depending on where you are in the country, you might not be covered by one of these, but in other parts of the country, the coverage is fairly robust. And we are creating essentially a platform, actually, that will enable HIEs to be able to share data directly with patients, or apps or platforms working on their behalf, easily in response to a query, a query based on demographics. Pull that data in, make it available with patient consent for research and patient care. And with that, I'll stop, and thank you again for the opportunity, and looking forward to the discussion.
Thank you very much. If there are any clarifying questions for Dr. McGraw, we could take those now. Otherwise, if I could get all of our panelists back on camera, and Mike, Dr. Jeff, if we could get you back on camera, thank you. Dr. Watson, would you like to read the first question from the QA?
Sure, and it's somewhat long, but it's more of a statement and a question at the end. It's really important to distinguish between assigned and ascribed race in discussing this literature. When loci data is presented in the literature by, quote, race, we need to let that stand and not assume predominantly ancestry. That stratification in the publication is only assigned/ascribed race, not ancestry. Race reflects an experience and social category. It is not an ancestry proxy. It has been used as such, but it captures other things, possibly some aspects of ancestry, but not cleanly so. Thoughts of the panel?
So
Yeah.
maybe Jeff, would you like to start?
Yeah, no, I mean, I agree completely. I think that that's something that I will say I think is evolving in our field. I think that there are a lot of groups, and some of which I'm a part of, that are working really hard to educate not only physicians, but also researchers on how we can change the way we talk about genetic ancestry, ethnicity, and race, and delineating those differences. So I definitely think that I definitely agree with you. And I probably, just from my bias training, probably have mumbled them up in my talk, but I definitely am knowledgeable of the difference, and definitely would encourage everyone else to also talk about them in those ways.
Dr. Landry, do you have anything to add?
Yeah, I was just going to add that, one of the things I always struggle in these types of talks because there's just so much and so little time to discuss. There are a lot of nuances. And I think as a field, I feel comfortable in saying we're just not there yet, right? We haven't figured it all out. We haven't systematically rolled out a plan for how we're going to address, and there's a lot to address. So I wholeheartedly agree. I think one of the things that the question is, should we even use race? That's often brought up. Secondly, can we use race as a proxy just because it exists in a lot of our EHRs, whereas ancestry does not exist in the EHRs? I think there's an inevitable interpretation. And so what do we do, and who do we train to interpret? So I think there's a lot of layers here. But as a sort of second, Dr. Jeff's comments, that there are groups who are working on this. And I think that the issue is there's a lot to detangle here, and that there are groups who are working on it. And then my vision of the future is that we will have this all worked out, and then we will have a system that we can roll out, and maybe genomic medicine, I don't know what year we propose that it'll all be worked out, but maybe in the future we can sort of say, this is how it should be done, and this is the system that we put in place to do that.
Did Dr. Horwitz or Dr. McGraw want to add anything?
I agree with everyone. This is very complicated. Race is a social construct, period. But ancestry does have some other features to it, and disentangling those two and not misusing them is really important.
So Dr. Landry, your comment, should we even use race, blends into the problem of not having race for COVID mortality. Do you have thoughts on how to resolve that?
Yeah, I think the question about should we even use race, is always, I'm always conflicted, because the issue with a learning health system, the issue with just presenting data is using what you do have. And I think that the reality is that the system that we currently have uses race, and it's not, we used to say that the conversation used to be about self-described race. Now we're pretty confident that most of what exists in our electronic health record system is the intaker appointed race, which could be any number of individuals. It's just very messy. I do think that there is some value, though, in perfecting the system while still presenting the data as we have it, with the caveats that go along that this is how this is, you can't interpret this to mean this specific thing. I think the sort of putting forth that we don't use anything until we have defined the classifications and the variables and how we're going to describe populations correctly puts us in a position where we're not going to capture what's going on in communities. And so I do think that we have a split task here of building the system that does it correctly while also using the information we currently have and just trying to create the correct interpretation of that data as we see it.
Thank you. That's a great answer. I would encourage all of our attendees to put questions in the QA, as well as to raise your hand if you have questions.
I do want to, while we're waiting, was there a raise hand? I thought I saw someone coming off mute to comment.
I was just going to continue to comment, but it's okay.
No, go ahead, please, Dr. Jeff.
Yeah, I was just going to say two things and kind of picking up what Dr. Landry just said. Like, one is in one of the examples I showed, the experimenters actually did remove race and actually did a worse job of predicting the outcome than the inclusion of race. And so similar to what was said before, it's not that we should not use race at all. It's just that we should use race and describe race in accurate ways. And so what does race mean? Race is a social construct, it is an experience, but that experience does affect health outcomes. And so it's not to say that these things should be ignored, but these things should not be used to describe holistically that this is the causation for a particular outcome. Another thing, to go back to the very first comment, is that even when we talk about genetic ancestry, we have to be really careful on how we even use that. Most genetic ancestry calculations are dependent on a reference population, which is confined, or are dependent on the population in which it was defined. So there's a lot of work that we have to do, and really we have to understand, well, what is the information we want to get out of this that is going to inform what we are ultimately trying to return to a patient. And that is, what is the interaction between the genome or genetic architecture in a given disease after we take into account all these social determinants of health and so forth.
So we had a second question, but I think it's been addressed, but I'll see if anyone has anything else to add. Race is an experience, an important one. It captures many things people go through that impact the expression of many omics. Won't we lose information by not capturing the social construct that it represents? So I know you did address that. And does anyone have anything they'd like to add?
There's a question by in the comment. I think Cynthia James is going to come off of mute to ask that question.
Yeah, this is more a comment. So in addition to being a genetic counselor, which I'll talk about more tomorrow, I've also spent a career doing research in rare cardiovascular inherited cardiomyopathies, and we collaborate a lot internationally in order to have adequate statistical power to build interesting models. And I think appropriately, we're talking about race versus ancestry and the conceptualization of race within the American healthcare system. This is an NHGRI conference, but I will, taking a step back, and Dr. Landry's sort of model with international on the outside, this is a recurring challenge for us in some of our international cohort studies, because that's a variable relevant to us and almost absent from their cohorts. So I'm sort of taking the opportunity to ask this smart group of people who have thought about this a lot better, more than I have, to sort of comment on that or tell me how you approach that. It's a regular challenge for us. Or maybe other people have the same challenge.
Yeah.
Any of our panelists want to weigh in?
I'll take a stab at it. I think one of the things that I'm hearing is there's both the issue of modeling a variable that may not be captured in all data sets that we think is important. The other is the interpretation of that. And I think that one of the things that is just really helpful in sort of helping us sort of think through that is this idea that sometimes we want to include race because we want to capture population groups in a biological, geographic way. And if we are thinking about that, then I think that one of the things that we should just really understand is that that is not what race is, right? So it's a social construct. It's not a social construct that's exclusive to the US. However, it is a social construct that captures an environmental experience that we may see in other countries, but requires a certain makeup of those countries to be able to discuss in context. And so I can imagine a sort of data landscape where we're thinking about race and we think about whether we expect, as Dr. Jeff and Dr. Horowitz mentioned, the idea is the experience. And if the experience is racism, and I'm not saying it is, but if that is what the experience is defined as, and I think we need to define the experience, then which populations do we expect to see that variable be meaningful, right? So there's some epidemiologic study design here and thinking about where do we expect to see, however we're defining race and what we think it is, to be valuable. And then the context of the populations or the cohorts where we don't expect that to be valuable, then maybe those are excluded from the analysis. I also think that the question here is, if we think the definition of race in a global context has value, then we do need to think about how we can capture that data, even though it may not have been originally a part of the data set. And so I think here the first step is defining what you want race to mean and what you think it means as a social construct, which is a messy area. And I'm fumbling all over it as I discuss it. But I think it's, you know, it's sort of, I think in terms of the investigators' questions, you have to think about what this variable is capturing for you and make sure that you're not saying that it's capturing some biological difference, in which case you're ascribing something that may not be in all populations in your integrated cohort.
Thank you so much. That was a great answer. Dr. Ginsburg, you want to come off camera and ask your question, or come on camera, excuse me.
Sure. Hi, everybody. I'm just going to pick up on something we were talking about in the chat, and really appreciated Dr. Landry's highlighting the perpetuation of bias throughout the translational continuum. And it struck me that we really don't, at this particular workshop, have a great representation from genomic-enabled learning healthcare systems that are serving underrepresented minorities. So that could either be because they don't exist, or just because we don't know about them, or some combination of that. So I really wanted to hear maybe from the panelists about how can, and Mark Williams had pointed out that there might have been a failed attempt to create something like that at Meharry with Vanderbilt. So maybe somebody could highlight perhaps why that did not work out. But it just seems to me, I'd like to have your opinions on how do we engage health systems that are serving the underrepresented people of our country in this dialogue, because it's so critically important to change the translational continuum, as we heard earlier from Dr. Landry.
If our panelists like to respond.
Well, I mean, I think there is increasing representation. I think, you know, Vanderbilt and Meharry, I think Meharry is doing some really good work. I know, like in our area, the Federally Qualified Health Center leaders are our co-investigators in our work. And I mentioned before AIM-AHEAD, which is the artificial intelligence machine learning large initiative that the NIH funded, where minority serving institutions and other diverse institutions are coming together to build a lot of computational infrastructure. So I think this is increasingly happening, but it's definitely not happening to the extent for which we want it. And so what often ends up happening is an institution like, you know, some of our institutions in New York City, where about half the patients are considered medically underserved or racially and ethnically underrepresented in the research enterprise, come to these meetings to talk, as opposed to some of our other partners.
Thank you for that, Dr. Horowitz.
Dr. Watson, do you mind if I chime in?
No, please go ahead.
Yeah, I mean, without a health system view, I mean, obviously from the Invitae point of view, we work very hard to try to increase the diversity of patients who receive genetic testing, who receive recommendations to get genetic testing, who have genetic test results that are available to their clinicians as well as to them. But in terms of, you know, I just don't want to discount the model of engaging the patients directly on some of these issues and working with their advocacy groups who are equally as interested in resolving these problems of disparity, if not more so. Can we take advantage of some of these initiatives like ours, but also other federal initiatives that are aiming at more and more data going to patients that will allow them to take more affirmative steps with their clinicians? People don't treat themselves, but also engaged with advocacy groups that they already trust in terms of, you know, just powering research and discovery. So, and again, not discounting all of the work that is important and necessary to do to change the systemic biases in the infrastructure of healthcare. Patients can't be asked to solve it all themselves, but we shouldn't discount them as part of the solution.
Thank you. Before you, Dr. Jeff, before you go, I do just want to address the one of the things that came up, and it's in the chat, and I also want to talk this issue of capacity. As we talk about, you know, describing things as, you know, failed attempts or whatever they were, I think what the message driving home was that there's inequities in capacity that exist. And as we think about the tenor of that we want to have as we end the day, thinking about some best practices. One of the really good best practices I saw in this space of capacity building, of addressing the pipeline of researchers across multiple spaces. When I think about the NCI work, a partnership that I actually came up through, thinking about these P20 partnerships. There are P20 partnerships and U54s out there that are meant to pair cancer centers, but some institutions with minority-serving institutions and historically Black colleges and universities. And what I like about these partnership buildings is that they intentionally build capacity of diverse researchers and researchers that are historically underrepresented in the pipeline. And they do it in a very intentional way and provide the appropriate resources so those faculty can get the support they need along with the mentoring and as well as the pilot data. So I really want us to think about looking at some models that have successfully done this in pairing MSIs and HBCUs with other centers to address this pipeline issue. But I see Dr. Jeff, after your comment, we're going to go to Dr. Landry, who's had their hand up. And then there's a question in the chat from Terry.
This will be really quick because I essentially was going to say the same thing that you just said. I think, and I think Terry was touching on it in the chat too. I think one of the things that we really have to address is the pipeline and also making sure that these minority institutions have the capacity to do this work. One thing I always say is that it's not trivial for a person of color to come up and talk about these disparities. That also, takes a toll. And so thinking about these institutions and what they're already dealing with, being already under-resourced in the jobs that they have, are outlined to do, then having the capacity to do the additional work without the resources is a big issue. So I agree with everything you say. I think that's part of it. The other part is kind of what Dr. Horowitz was talking about, bringing people to the table, not only just having a seat at the table, but being welcome and encouraged to be active participants. And I think that goes to this, that applies here as well.
Dr. Manolio, would you care to come on camera?
Sure. Yeah, I had a comment on a previous thing, but just focusing on this one, I couldn't agree more with Dr. Jeff, and I think having been one of the architects of the experiment with Emerge and Meharry, I think it's a perfect example of us moving to equality rather than equity, and we basically said, okay, come and join us and, grab for the apple in the tree, to use your example there. So I think that is something we have to be much better at, and infrastructure and capacity building are real things and real needs. The role of research institutions in doing that is a debatable point, and is something that we continue to struggle with and would welcome your advice on. But I'll come back to my other question after. This is a more important discussion, I think, so we'll let this one run.
Dr. Landry, is your hand still up?
Yes. So I was just going to say that I love the conversation. I think I see it in two ways. I think the diversifying the research participants is an important goal. But when in Dr. Ginsburg's question, I also hear the idea of sort of research led by minority serving institutions. And I think that has value. In a lot of the work that I've done, there's this concept of no research on us without us, this sort of for me, by me. And I think that there's a strong feeling, and this relates to all of the conversations we have about trust, that people feel like they're being left out, that they're being asked to hand over their DNA, and that there's value in their DNA, but they won't ever benefit from that. And I think that there is some value in communities by having minority institutions from their communities sort of be a part, have a seat at leading the research. And I think that when we think about it being debatable about whether we have a role in this, I think that it's important to think about the early 1900s when the Carnegie Mellon Foundation and American Medical Association had Abraham Flexner produce a report that looked at medical education across 155 institutions in the US. The result of the Flexner report, which is highly regarded across medical education, suggested, and it's now been categorized and classified as both racist and sexist in sort of its language, suggested that the minority serving institutions, specifically HBCUs, weren't high quality, but also weren't necessary, that minority physicians should not be trained in the way that they were. The result of that was that of the 7 HBCU medical schools, 5 were closed. 2 exist today, Howard and Meharry. 2 additional HBCU medical schools came about later. That's Morehouse and Charles Drew. And I think that when we think about that and medical schools being tied to academic medical centers and being sort of a vehicle for a lot of this type of thing, I think it's important to think about both what Dr. Jeff reminded us earlier about systemic racism, but also thinking about capital, right? We're talking about infrastructure and capacity building, and all of that takes money. And so do we have a role? Yes. If we think about the history, I say yes. And I think I'm happy to debate it, but I do think that there's an important history that we need to understand as we have that debate. And so with all of that, yes, there are endeavors that are focused on diversifying genomic research, but there's also endeavors that are focused on having minority-centered institutions lead some of that in terms of learning health systems. A lot of that foreground work is going on to building biobanks at minority-serving institutions. And I think that that's just maybe not represented here because a lot of that's in its early stages. And I think that the question of that was very helpful because I think discussing this in this discussion has been very important to our overall conversation.
Thank you.
And there was one additional question in the Q&A, and we've somewhat hit on this, but I really like this. It's asking for direction in which the NIH or NHGR should take to move this forward. Dr. Jeff hits an important point. Ancestry only clusters people to populations we have defined as we have defined them. What would the panel like to see the NIH or NHGRI specifically do to move that space forward? I'll start with you, Dr. Jeff, and then we'll move to the other panelists. Maybe if each of you want to comment specifically on this.
Yeah, I believe that there was an NHGRI conference, and I missed it, on one of the futures, the bold predictions, I believe it was called. And there was a bold prediction on if we no longer use race or the use of race and genetic ancestry in genetic association studies. I think that happened. I'm not quite sure. I don't remember. It was, I think, a year ago. If we touched on the definition of genetic ancestry versus genetic similarity versus race, ethnicity, and all of the above. But I do think it would be a good panel to see. At NHGRI, what it would look like would take some ironing out, but I would definitely attend.
Anyone have anything to add?
Well, I guess since you offered, I would say, it would be terrific to see more funding go to advocacy groups that already have the trust of their communities, especially communities underrepresented in research, in order to provide some funding for them to be able to set research agenda, power studies, be able to work with their participants, similar to some of the examples that have been that I brought up and others have brought up in the chat. That this is not to the exclusion of the traditional medical system and the medical system that historically Black colleges and universities, who often themselves have great relationships with the advocacy groups in their communities. I just feel like some seeding of some of this, not necessarily at the institution level. You might get some very interesting results out of that. We certainly have.
And Devin, your point was well taken, and also highlights something that Sharon Terry put in the chat, of thinking about resources for engagement specifically. And this speaks to my role as a chief engagement officer. I even think the fact that there are entities in the NIH that have this concept of having a chief engagement officer or someone specifically dedicated to ensure the driving of equitable engagement of multiple stakeholders at the onset and from the get-go is actually a concept that I would love to see duplicated across other programs. So you're directly speaking to that.
Yeah,
and
I saw that too. Yeah.
I'll ask Carol and Dr. Landry if they had comments on this, and after that, I know Dr. Manolio had a follow-up question.
Yeah, I think that, in general, the way that NHGRI and it, when I went to my first NHGRI meeting, I would never have imagined it turned out this way, but it did. And that's a good thing, which is that the NHGRI has been proactively looking for opportunities and then being open to pursuing them. So NHGRI is moving forward in encouraging engagement, then being more insistent for engagement. There are opportunities to think about, do you want to make sure engagement is budgeted in grants that are coming your way? Do you want to have engagement prioritized in RFAs where people are developing engagement infrastructures? So I think that as, for you who, who fund so much of what we do, and a lot of us wouldn't be able to do the work we do without your funding, that carrot is really, really important. I think these incremental steps that you're taking, and each project you're doing, you're going a little bit deeper into what is equity, what is justice, what is engagement, how do we ask for it, how do we ask for funding, how do we ask for accountability for what you're doing, and doing that strategically, I think can have a huge impact, and I think others at the NIH could follow suit.
I couldn't agree more. I feel like I'm defined as an early career scientist, but I feel like I've been in this space for a while. And I will say that I'm just really encouraged by what's going on now. I mean, I think Dr. Horwitz, you mentioned the AIM Ahead Consortium. Earlier, Dr. Wiley mentioned the PRIME Consortium. I think about the RFAs that I've seen in the last couple of years. And I think when I was actually a doctoral student, I was suggested not to focus my career on health disparities because it would limit me from funding. There was just a small bucket out there. And if you were going to, if you were going to focus your career on that, you weren't going to eat every year, right? And so, and now that I think about the RFAs that I've seen, it feels like equity is at the forefront. And so I think that, yes, there's still room to grow, but I do think that NIH and NHGRI specifically is really moving in the right direction, and I've been encouraged by being in this space.
Fantastic. If there are no other comments on that, then Dr. Manolio, what is your next question?
Sure. Yeah, and there are other comments in the chat on this topic as well. This is actually going back to Dr. James's comment about people in other countries not understanding what we're struggling with in terms of race and ethnicity, and having done some work, not nearly as much as you have, Dr. James, in those settings, you almost want to hold up a mirror and say, oh, really? There's no discrimination in your country. It just goes by different names, or it's based on different characteristics of individuals. I think one only has to look at recent authors. Isabel Wilkerson captured this quite well, and pointed out the extreme that the U.S. represents, but it happens where there are people, there is this kind of discrimination. So I think trying to frame it in terms of the areas where they may be experiencing this kind of discrimination and health disparities can sometimes help them to understand where we're coming from. On the other hand, we have to recognize that race, and particularly Black race, is I wouldn't say it's a uniquely American problem, but it is an extremely American problem, and one that others do have trouble understanding.
Thank you for that comment. Anyone have a follow-up?
Yeah, I want to say, I think there's some countries and regions of the world have different forms of discrimination and racism. But looking at socioeconomic differences and social class differences is a worldwide phenomenon. Looking at LGBTQ discrimination, looking at discrimination against people with different abilities. So there's an underlying harmony to these that's unfortunate, but that's what we need to look at, and that's going to go in general to looking at kind of the racial aspects of things and the social aspects of things.
I have a question for Ms. McGraw. When you are looking at the enrollment of your patients/participants in your citizen platform, Is it equally represented for, and I realize you referenced before that there's underutilization of genetic testing for people who are non-European ancestry, but when of the people who do have tests, do you see proportionate enrollment in your research platform?
So we don't have data broken down by race, which we should. And it's something that I'm taking back from this conference. I suspect that, we sort of have these focused initiatives with different groups. And so depending on the penetrance of the particular condition, the racial makeup of the pool of people using Citizen is going to vary pretty significantly, but is probably still underrepresented. We have endeavored to do a lot more outreach to advocacy groups that are representative of populations that are typically underrepresented in research and for whom clinical care also often suffers. And the Touch the Black Breast Cancer Initiative is the group, was the first group that we began working with, where it was specifically designed to be an initiative to try to enroll mostly women with triple negative breast cancer, and to work with the organization in order to understand more whether there was reluctance to be considered for clinical trials, what was the basis of that reluctance, and whether there was interest of these women in enrolling in trials if they could find out more information about them. So it's a long-term engagement that we have with them. When we ask patients if they want to share their data, the percentage of patients who say yes also varies by disease category. So for rare neurological disease groups that we are working with, it is most often very young children who are impacted at birth. There's a genetic component to the disease. The parents are highly motivated to gather the data, both in order to power the best possible care that they can get for their child, but also to power research. And the percentage who say yes is close to, if not right at 100%. I feel like statistically you can't say 100% because there's probably maybe one or two that have said no, but most of them do, because they're highly motivated to seek options for their children. In terms of cancer, on average, it's 76%. And I would say if we went down the cancer subtype, it would probably vary there as well, because of the advocacy group relationship tends to mean a lot in terms of how motivated and dedicated people are to going through the process of having us gather their data. We do all the work, but it's not without some lift and risk for them. So do they want to take that on? Are they willing to share their data going forward? It will vary a bit more, but again, the work that we did with LLS, there was heavy participation. I should get the statistics on the percentage who said yes for that. It's probably close to 100. Similarly, in the work that we're doing with Cholangiocarcinoma Foundation, the percentages are high. In breast cancer, it varies because not because people are not dedicated to finding something, but we have high percentage participation in our partnership with Touch. But again, it's a smaller organization with heavy hands-on outreach to their members. Whereas, maybe some of the larger advocacy organizations are a bit more dispersed. I don't know if that answered your question, but it really does vary. And I think you're right that it would be helpful for us to have better data on, so that we can be doing even more than we're currently doing to move the needle on some of these diversity issues.
Thank you. That's a very interesting answer. If people have questions, please put them in the QA or raise your hand. We've drifted a little ways away from learning healthcare systems. I guess one question I would have is, if patients have better access to their genomic data, would that push genomic learning healthcare systems forward? Or Or if not that, what?
Gail, I would say that, it remains to be seen. I think we define access in very specific ways. And I think there's bias in that, right? So I'm an academician. I work in a major academic center. Internet and bandwidth is not an issue for me. But I also worked on a cohort with diverse participants using federally qualified health centers as our strategic sites during the pandemic. And I can say that access to the internet, even mobile devices, can be an issue for a lot of people. And so when we think about how can we create access or a more universal access to electronic health records for patients, I think we have to think about which patients would have access based on the strategies we employ. And I think that there is just a real issue of infrastructure that needs to be met for us to be able to have broad access for vulnerable populations. I think if you think every technology strategy, and if we just, again, thinking about COVID as sort of our exemplar of how our infrastructure lacks equity, when we thought about who could sign up for vaccinations, and we were asking people to go online and sign up for vaccinations and get appointments, we actually had to create navigators for a lot of people if we wanted to help them achieve getting a vaccination appointment. And I think that the same is going to be true if we think about robust genomic learning health systems and how we can get people access. We're going to have to create both a person in technology strategy. We're going to need people as vehicles combined with technology to help us get there. And that, again, goes back to capital and investment.
Yeah,
Dr. Landry,
who signed my parents up for their vaccines. Others of you were as well. That example really hits home to me of access. Thank you. Sorry, Dr. Watson.
No, I agree, Dr. Jarvik. And Dr. Landry, I was going to say, this goes back to a point that was made in one of the earlier sessions, learning from other sciences as well. This concept of patient navigation, we actually know that it's worked. It's been proven and effective to work in the advocacy space and helping patients navigate a lot of the barriers, even the systemic barriers that exist in systems. And we saw it, we need to pull that. And I think this concept of team science more in the GLS space, pulling from other areas of the academy that have worked, particularly as it relates to patient engagement, I think is something we can definitely learn from. I see Dr. Williams has their hand up.
Before you ask your question, Dr. Williams, I was just going to, before we leave this subject, also comment that, a part of access is education too. And so it's one thing to have access to the data. It's a completely different thing to know what that data means and how you can use that data. And so, for example, going back to COVID-19, I had family members who went and got COVID tests or went and got antibody tests and didn't know how to interpret the results. Or friends who I recommended to, sequence their genomes, got the raw data and do not know where to begin. And so I think we still need a bunch of resources put in place if we, get to that point of giving patients access to genomic data, access to their EHRs on what it means. And so the education and even the language that we use can sometimes be a barrier for minority populations.
Agreed. Thank you, Dr. Jeff.
Mark.
Great, thank you. I wanted to answer your question as well, Gail, because it's one of my favorites. I think the answer is an unequivocal yes. And just a couple of examples from our experience that I'll briefly relate. One of the successes of the MyCode project that you heard Adam Buchanan talk about earlier today was 2 years prior to starting the project, ongoing engagement with both patients and clinicians about what the project should look like and how information should be prepared and what sort of educational and support materials are needed. And so that has really led to, and then of course this is ongoing. So it's not just we have groups that we meet with on a regular basis. And that has really led to not only some of the transformational design elements that Carol referenced earlier in her experience, but also I think has really gotten the participants much more engaged with the results and being more empowered to kind of act on things. And we have some results that show that. But the one that really struck me that I think is directly related to this is that one of the first projects we did when I went to Geisinger 10 years ago was designing a patient-facing genomic test report. And we did that with funding through PCORI, and we actually had patients on our investigative team, paid patients that helped us to design the report. First of all, they taught us things about how to design a report that we would have never thought of. So we definitely learned a lot from that. But my favorite experience was one of our rare undiagnosed patients where we found a causal variant, ended up going to the NIH Clinical Center for a 1-week evaluation for their condition. And they were had their initial meeting with the clinician down there, and they said, you know, we've got all your records, but we don't have your genetic test report. We really can't move forward without that. And she said, can I have your computer? And she typed in, logged in, pulled up the patient-facing report and said, there, we can now we can move forward. So I think that is a really eloquent answer to the question of, you know, does patient engagement, you know, promote precision medicine, precision health? I think absolutely, if it's done right.
It's a great story. I have a question for Dr. Horowitz. First of all, I was disturbed to hear people are pushing it back against having even one patient representative or physician be part of the study design. But you know, there has been raised in the community a concern that, you know, that one patient representative is often someone who has more time, may not be completely representative of a lot of people in the study, may often more educated. And how do we really reach back, in addition to having patient representation on studies, how do we really reach back to get a wider swatch of what our participants hope for in a research process?
I think it's a good question. I think, you know, every learning health system has to figure out what their organizational structure is that's going to welcome and value engagement of diverse populations. For us, we found a lot of times that having a central stakeholder board that's focused on a certain area, like we have a genomic stakeholder board, where you bring in a diverse group of people, you fund them really well, you build their capacity, and they meet regularly for years. They become their own system and they grow and they get stronger, and it gets easier and easier for them to take on more projects and for their voices to be heard and valued. And so I think people do need kind of a central group of people. And we've found over time that it is often helpful to find those kind of folks who are either tied in with an organization or have other reasons that they really want to be part of a longitudinal effort. So I think you need to have a core group of people that are going to work with you on the long haul, and you're going to build trust and you're going to build relationships and you're going to learn to work together. Once you get beyond that, there's tons of methods you can use to reach out to larger communities. So when we wanted to do research on how patients and clinicians felt about using big data efforts to research health equity, we went out to all the meetings in our community. So we went to all these clinician meetings and said, you know, can we have 10 minutes in your weekly or monthly clinician meeting to ask you a question? We went out to tons of community meetings. There's lots of community structures with 10 to 50 people on them. And we just did a listening tour and learn. So I think, you know, you have to figure out your structures, and then there is room for focus groups and surveys and those kind of listening sessions. So I think you need to have multiple ways to do it. But my concern would be that the concern that I'm only going to have 1 or 2 patients, I'm only going to have 1 or 2 clinicians, so that's not going to be really representative. My feeling over time is that a lot of people who are saying that really haven't done that much engagement and have a little bit of nervousness or uneasiness about getting involved in it. And start small. It's better than not starting at all. And there's lots of us in this group who have a lot of experience with it, and we'd be happy to help.
Wonderful.
Thank you so much. And I think that's a great way that they're happy to help, as well as the comment by Dr. Rex Chisholm that, been very optimistic about this discussion. As we wrap up this amazing day one, we'd love for each of our panelists just to spend 1 or 2 minutes with some closing comments as we think about the role of GLHS in increasing health equity and access to genomic healthcare as we close out. And we'll start with you, Dr. Jeffs.
Yeah, I think one of the things that I'm extremely passionate about as we develop new technology and new approaches in our field is that we be mindful, that we think about all the different stages, we be mindful, we be inclusive. And we also really think about what are the ramifications of said technology or approach and who will be the person benefiting from it. And so I encourage us all to be, as we are already, critical of the work that we're doing and constantly going back and checking in with the community and checking in with other researchers and patients and making sure that what we're doing has beneficial value to the communities that we want it to reach.
Dr. Landry?
Yeah, I will say that so much of the expertise or advice I've gotten throughout my training is really about sort of building a platform and sort of running with it, right? So that you can be successful, try to reuse it. And I think one of the things that is sort of begging of attention at this current moment is that there are many platforms, research platforms that have been built that do not have equity as their focus, do not have equity built into them. And so I do think as an entire research community, it's now our collective objective to sort of go back and rethink that. And that may mean that your next grant, you can't just take what you have and just sort of run with it and apply it. You may need to think about building in collaboration with others to help to think about how you can have equity at the focus or make sure you're asking equity focused questions to really sort of capture it. I think we need our entire research landscape to really sort of be re-engineered to capture the information that we need. It's not an individual endeavor and it's not the niche focus of a few. And so I would just encourage everyone to sort of think about it from that standpoint. We all have the capacity just to add, a focus, a metric, a question in our next research question for the grants that you're working on right now as you sit in this conference, thinking about, okay, what's the equity focus? What's the variables that I need to capture? And let's build this landscape together.
Dr. Horowitz.
I think this is all really exciting, and my concern is that I'm seeing a mix of two things. One is equity tourism of people who don't really understand and aren't reaching for help and just feel like they need to check the box. So that's why I think it's so wonderful that this group is together where there's so much expertise. But the other is equity fatigue, and I'm already hearing people kind of itching to move on. And oh, if I hear one more thing about DEI or JEDI and all these different things. So I know it's easy to, I never thought that we would have so much of a focus on equity. I was stunned, I'm sure a lot of you are, that the NIH put out these calls for research on structural racism. I think this is all really exciting. I don't want, therefore, it to feel like equity and justice are a shiny toy that are going to go away when another shiny toy comes about. So I hope we can continue this focus in the long haul, because it's going to be a hard one to move on from if we don't do it right.
Ms. McGraw.
Well, in keeping with the theme of sort of most of my comments today, genomic learning health systems are not exclusive to the healthcare system community, that there is a role that patients and communities can play in facilitating learning from genomic and clinical data. And there are models out there that exist today, and they can create important partnerships with these organizations, or even be, permitted to run with the ball themselves a bit more than they have. And while this is not a singular answer to or solution for diversity issues, I think it's yet another way that you can put in the hands of these communities a path forward that allows them to shape the agenda to their needs, in addition to helping you shape yours.
Thank you.
So thank you, everyone. Thank you to my co-moderator, Dr. Jarvik. Thank you so much for joining us today. And thank you to our panelists. You all have really set the tone for closing out a great day one, and definitely pointing out some amazing issues in this concept of one of the really take home messages that I heard too was making sure that engagement is not an afterthought, and making sure that it's appropriately resourced up, and making sure that it's not something that is just a part of the trend, but that it's sustainable, and that that we change the landscape so that it definitely is threaded throughout all the work that we do. So thank you all so much. And I definitely hear for all my colleagues that may be at the NHGRI or NIH, we definitely have marching orders ahead of us. So thank you all so much.
Okay, great. This is Pat Taberka. I just want to thank everybody for attending day one, and just remind folks that we have 3 excellent panels tomorrow as well. And we will start promptly at 11 o'clock Eastern time. So thanks, everyone.